तुम्हारे क्लास में प्लीज है फिर सब करा दे मीटिंग रिकॉर्ड कर रही है अब वो नहीं आ रहा तो मैं ऊपर जाके चेंज कर लेती हूँ लेकिन नहीं आया
अरे नहीं खाना खाया लगता है ना टेबल बदलना अपनी किस्मत ही बोलते हैं पेपर कौन
Okay, good afternoon. We'll start in 5 minutes. Please tell your classmates to join in.
Yes, doctor.
Okay, good afternoon. So this is your last topic for your next long exam, which would be next week. So this is causal inference. So what is causal inference? Okay, learning objectives for this class would be at the end of discussion, the session, the student should be able to discuss the philosophical history of causation, discuss causation in the epidemiological context, such as the Hill's criteria for causation and your sufficient component cost model, discuss the potential outcomes model of causation, and discuss the requirements for causal inference. So what is causal inference then? So this is determining whether a statistical association is causal or it is the cause of the event. For example, coronavirus. what would be the statistical association of being infected with coronavirus if you have the COVID-19 virus? Okay? And you have to have a statistical association, and you have to remove the element of chance or variance before you conclude anything that it is statistically significant, thereby causing a certain event or an occurrence. Right? So it's embedded in public health practice and policy formulation. So the usual objectives would be for causal inference would be to identify the cause of disease, as I've mentioned in the prior example, and to decide on the effectiveness of public health interventions. For example, with the COVID-19 as an example, would lockdowns be statistically significant in reducing the propagation of the COVID-19 virus? Things like that. Okay, so it is very much embedded in the practice of public health. Okay, so there are a lot of philosophies of causation. Okay, first reasoning would be your inductivism. So this is the philosophy of scientific reasoning. So you can make generalizations from observations to general laws of nature. So what generalizations can you make? Okay, so remember our culture and gender lecture way back in first year, for example. So generalization would be men are stronger than women because they are anatomically built that way. So you could generalize that most men would be stronger than women. Again, there would be outliers. But through scientific reasoning, we could deduce that most would be stronger. Okay. Again, with the obvious limitation that we have, outlier. So it makes an assumption that certain events would, in the future, follow the same pattern as they had in the past. So observers cannot perceive causal connections, but only a series of events in proximity in time and space. For example, I will pass PrevMed even without studying. Okay, so that is an assumption. Okay, but will it always follow the same pattern? Maybe not always. So you cannot make a generalization that you will always pass the exam without studying. So that is inductivism. Okay, so that the philosophy of scientific reasoning, making a generalization from general laws of nature. Okay. Another philosophy would be refutationism. Okay, what is refutation? Refutationism. So these are statements that can only be found to be consistent with observation, but cannot be proven or disproven in any logical or mathematical sense. So in contrast, you have an observation that is inconsistent with a hypothesis, implies that the hypothesis as stated is false, and so refutes the hypothesis. However, logical certainty about either the truth or falsity of an internally consistent theory is impossible. So you have a general observation, but it cannot be proven or disproven in any logical or mathematical sense. Okay, what are some examples? Can you think of anything? The presence of for example, air. Your air is around you, but can you prove its existence? And it cannot be proven by any logical or mathematical sense. You cannot touch it. Okay? But the absence of it, of the atmosphere, especially if we compare it with other planets, prove that it is not compatible with life. So, refutationism. Compared to inductivism, it has some general law that is followed. Okay. Refutationism is something that is consistent with observation but cannot be proven or disproven. Okay. So another would be impossibility of scientific proof. So proof of causation is impossible in empirical science, and that includes epidemiology. So what are the usual fruits of research? So are at best only tentative formulations of a description of nature. So even when the work itself is carried out without mistakes. Okay. So experiments, the researches that you have done, there's no perfect research. There's no perfect, unbiased, randomized controlled trial, etc., etc. Thereby, it's close to the impossibility of scientific proof. And this tentativeness of our knowledge will not prevent practical applications, but it should keep us still critical and skeptical, not only of everyone else's work, but of our own as well. And that is why we teach you critical appraisal of journal. You cannot take every journal as a matter of fact. Even the books that you have in medical school, yes, even the books that you have in medical school, you cannot take it as 100% fact because there's impossibility of scientific proof. Okay? So in epidemiology, how is it used? Okay. So it's important first to know the terms outcome and the cause. Okay. First, let's deal with outcome. So this is a non-recurrent event such as death, first occurrence of a disease, or whatever. Okay. So we will assume that the outcome of each individual is not affected by the exposure and outcomes of other individuals. So for example, non-recurrent event, you took the exam, the outcome would be your test scores. Okay. You take your weight, the outcome would be your weight, etc. So that is any non-recurring event. Okay. So cause. So this is anything, an event, a condition, a characteristic that precedes the outcome or disease onset, and that had the event, condition, or characteristic been different in a specified way, you ask, could have the disease occurred or not at all? Or it would still occur but at a later time. So what are examples, especially in epidemiology? So for example, you have diabetes. So what's the cause? So for example, if I am fond of eating sweets, so what's the chance that the diabetes as a disease would occur in the individual? What's the chance that it would not have occurred at all? Or is there a chance that it will occur, but it at a later time? Or if you stop eating sweets, would it delay progression? So that's a cause. So anything that precedes the disease, and if you change it, it would have a different outcome. Okay. So that's the relationship between your outcome and your cause. Okay. So this is an example. For example, this would list standardized death rates from cancer of the lungs per 1,000 men aged 45 to 74 years in relation to amount of tobacco smoked, which is estimated from a backward inquiry into the histories of the patients with cancer of the lung, and B, from the present forward inquiry into the mortality of doctors. So there's a backward, it's a retrospective, forward study. And what does it show? So non-smokers, 0.11. Forward study, 0%. So if they stop, so it would have less percentage of the disease occurring. Backward, since people are still smoking, you have a higher chance of disease to occur. Okay. Then you have your Hill's criteria for causation. So what is Hill's criteria? So conclusion of causality is a judgment based on a body of evidence. So this was way back 1965. And there are 8 guidelines for judgment of causation, which we will discuss one by one. Okay. One is strength of association, your biological gradient or your dose-response relationship, specificity of the association, temporality, theoretical plausibility, coherence, consistency, and experiment. Okay, what are these guidelines and what do they mean? Okay. First, we go with strength of association. So, a strong association rules out that the association is entirely of primarily due to unmeasured confounders or other source of modest bias. Okay. A strong association is neither necessary nor sufficient for causality. And a weak association is neither necessary nor sufficient for absence of causality. So what would be examples of a strong strength of association? For example, your lung cancer. What is it strongly associated with? Anyone? Smoking. So smoking has been very much linked to lung cancer. So thereby, the strength of association is very strong. Okay. Is it necessary for causality? Remember, there are other causes of lung cancer. Is it sufficient? Not always. Because there are smokers who will not develop lung cancer. Okay. Weak association, neither necessary nor sufficient. So if you are a smoker, not if you are a non-smoker, does it mean that you will not get lung cancer? Not also. So that, but the strength of association would be very strong in this example. Next would be consistency. So what is consistency? So these rules out your hypothesis that the association is attributable to some factors that may vary across studies. Although lack of consistency does not rule out a causal association, okay, some effects may produce by their causes only under unusual circumstances or only among a specific group of people. Okay. And it's not a question of consistency in statistical significance because difference in significance could arise solely because of differences in sample size of the study. Okay. So they say that your hypothesis of the association is attributable to some factor that may vary, and thereby you must have consistency. But the absence of it will not rule out a causal association. For example, strength of association, your smoking example. So it is highly associated with producing lung cancer. We all know that, smoking. But it is not always the case because there are exemptions or unusual circumstances. For example, opportunistic infection. Okay, some bacteria would cause opportunistic infection, but only under unusual circumstances. So it lacks consistency. But what increases consistency when you're immunocompromised, etc., or among a specific group of people, you are very much exposed to a certain disease, then it will hold. For example, minors would be prone to asbestosis or any other respiratory disease because of constant exposure. So you have your strength of association, you have your consistency. Okay, specificity. So a cause would lead to a single effect, not multiple effects. An effect has one cause, but not multiple causes. Okay, and this is applicable especially so for your infectious diseases. So what causes your coronavirus? You have your COVID-19. What causes your tuberculosis? You have your Mycobacterium tuberculosis. Okay, so one disease is specific to cause a certain outcome. So it can be persuasive when, in addition to the causal hypothesis, one has an alternative non-causal hypothesis that predicts a non-specific association. For example, ovarian CA is associated only with ovarian endometriosis and not with any other type of endometriosis. So it's quite specific. So ovarian cancer will lead to ovarian endometriosis. Single effect will not have a multiple effect. Single cause and will not have multiple causes. Okay. Then you have temporality. Temporality is required for causation, but they provide no evidence for or against the hypothesis Okay, that C, for example, can cause D in those instances in which C precedes D. So observations in which C occurred after D merely show that C could not have caused D in these instances if it happens to go the other way around. So there's no evidence. Okay. And only when it is found that C cannot precede D in any instance can we dispense with the causal hypothesis that C could cause D. Okay, that is temporal. Okay, so these are, for example, these are usually your irreversible steps in biochemistry. Do you remember any irreversible step wherein your cause should be the effect because it cannot happen the other way around? And often these are roadblocks in disease outcomes because in biochemistry, once you've had that roadblock, the buck stops there and the reactions cannot proceed, thereby producing a deficiency. Okay. Next, you have your biologic gradient. Okay. So it is a linear or your monotonous trend. Okay. Could still be affected or caused by confounding. And it shows that a non-monotonic relation only refutes those causal hypotheses specific enough to predict a monotonic dose response curve. So if you will look at the graph, so your monotonic relation would lead to a reaction. But a non-monotonic relation only refutes the hypothesis specific enough to predict your monotonic dose response curve. So remember your competitive and non-competitive inhibition in biochemistry. So you will see that as it goes up, as you increase the dose, reaction would occur faster. Okay, so that is your monotonic dose response curve. But you also know that those would have limitations as well. Okay. Plausibility and coherence. So this is usually based on prior beliefs or current knowledge rather than logic. So absences of coherent information should not be taken as evidence against an association being considered causal. So the presence of conflicting information may indeed refute a hypothesis, but one must always remember that the conflicting information may be a mistake or a misinterpretation. Okay. So is it a possibility? Does it follow the general laws of nature? So it is plausible and coherent. So we cannot discount the fact that it is possible. But it may be that you did not witness anything or you did not actually see the event. And we have to be careful again because it may be due to misinterpretation or mistake, especially if we cannot see all the causalities. Okay, next, experiment. So the experimental or semi-experimental evidence, which is obtained from reducing or eliminating a putatively harmful exposure and seeing if the frequency of disease subsequently decline. So if we remove exposure, does disease decline? So it can be confounded or otherwise biased by a host of concomitant secular changes. So these are your experimental designs to see if your hypothesis is true or not. Okay. What happened? Okay. And then we have your sufficient component cost model. So this was developed in 1976 by Rothman. So remember your web of causation model as your models of disease causation. And this is where your sufficient component cost model came from. So this is to provide a general but practical conceptual framework for causal problems. So it describes conditions necessary to cause or prevent disease in a single individual and for the epidemiological study of the causes of disease among certain groups of individuals. Okay. So what do we mean by sufficient cause? So sufficient cause simply means it's a complete causal mechanism or a set of conditions and events that are sufficient for the outcome to occur. Okay, it's the minimal requirement for the outcome to occur. So many and possibly all of the components of a sufficient cause may be unknown, and this is usually labeled as U. Okay. What then is a necessary cause? So a necessary cause is a particular type of component cause that appears in every sufficient cause. Okay. So for each component cause in a sufficient cause, the set of the other component causes in that sufficient cause comprises the complementary component causes. Okay. So your necessary is part of your sufficient, is a subset of your sufficient. But that would be necessary for the outcome to occur, which you will see later. Okay. So component cost, so this would be your necessary but sufficient, must be defined with respect to a clearly specified alternative or reference condition. So this is called your reference. So what is this? So this is an event, condition, or characteristic, may not be a cause by itself or as an intrinsic property it possesses, but is part of the causal contrast with an alternative event, condition, or characteristic. Let's see. So what are the implications? So the induction period can only be described in relation to a specific component cost operating in a specific sufficient cause. So the induction period for the last component cause of a sufficient cause is 0. Okay. So induction period for the last component cause of a sufficient cause is 0. Sorry, my laptop's low-bat. So another implication. So two component causes acting in the same sufficient cause may be defined as interacting causally to produce disease except when E plus F produces the disease. Okay? And third implication, so the disease may have many possible sufficient causes, each composed of multiple component causes. Blocking any one component cause already prevents of disease by the pathway. So for example, you have your TB bacillus identified. Okay. Then you have your tuberculin test. So there are a lot of blocks. So you could block here or your BCG vaccine or your TB antibiotics. So there are ways that you could block it using antibiotics, or you could block complications using your BCG vaccine. Okay. Okay. The strength of a factor's effect on the occurrence of a disease in a population depends on prevalence of its causal complement and prevalence of the components in other sufficient causes. So for example, here, what are the causes? So it could be absence of your BCG vaccine, could be crowding, could be poor ventilation, causal, or sufficient causes. You have AIDS, you have poor nutrition. What are the limitations of the sufficient component cause model? So this does not depict aspects of the causal process, such as sequence or timing of action of the component causes, dose, or other complexities. So it does not directly help us decide which is a cause or not, and is not able to illustrate confounding or bias. Again, what are confounders and bias? So this would be variables that would affect your outcome, but not directly a variable. And bias would be your designs, either bias in your sample size, bias in the analysis of data, etc. And with the limit of our current knowledge, the remaining unexplainable variability in disease development is ascribed to chance. Okay, so that is your sufficient component model. Now we tackle potential outcomes model. Okay, so the potential outcomes approach was designed to quantify the magnitude of the causal effect of a factor on an outcome. And this is not done to determine whether it is actually a cause or not. So the quantitative counterfactual inference helps us predict what would happen under different circumstances. but is agnostic in saying which is a cause or not. And this requires commitment to define the cause of interest. So how do we define the causal effect then? So suppose you have a treatment variable A with two levels. For example, 1 is and 0, and an outcome variable Y. So 1 is death, 0 is survival. So treatment A has a causal effect on an individual's outcome Y if the potential outcomes under A is equal to 1 and A is equal to 0 are different. So A has a causal effect on Zen's outcome because, so for example, if he received the transplant, A is equal to 1, he dies 5 days later, or if he did not receive the transplant, then A is equal to 0, and he is alive 5 days later. So what could you conclude? Gets a transplant, dies 5 days later, does not receive the transplant, is alive 5 days later. So is the transplant sufficient or necessary or the causal effect of death? These are instances where you second guess yourself as a surgeon, especially if we look at cancer or other diseases. Had I not operated on that patient, would have my patient have lived 1 year longer? So cause and effect. So what is generally more useful in public health is an average causal effect in a population of individuals. So to define it, we need an outcome of interest. So the treatments to be compared, okay, and a well-defined population of individuals whose potential outcomes are to be compared. So you need the outcome, you need the intervention, and your population. And that goes your research. So how do we measure average causal effect? So for example here, half of the members of the population would have died if they had received a heart transplant. Half would have died if they had not received a heart transplant. So null hypothesis of no average effect is true, such that in this population, having a heart transplant is not the cause of death. Because either way, half will die and half will survive. So you have your central problem of your causal inference. So you have your missing date problem because only one outcome is factual for each person. And you have a comparison group. And this is used to represent this missing counterfactual scenario. Okay. For causal inference, we assume three things using the potential outcomes model. First is consistency, second is exchangeability, and the third one's possibility. Okay. So what is consistency? So this requires a sufficiently well-defined causal question. It assumes that either there's only one version of the treatment and everyone is classified and treated exactly the same treatment, but this is not possible in reality. As I've mentioned, there's no perfect RCT. Or there are multiple versions of the treatment, but the differences among versions are not relevant to the outcome. So you have your standard deviations, but it's not statistically significant. And then you can safely group these people together as exposed and more commonly applied, especially in observational studies. Consistency. So how do you define the causal question? So ideally, the description of the causal question should include the specific factor being considered, the outcome expected, the group of people to which the hypothesis applies, and the amount of the factor needed to cause the outcome, the time needed for the factor to cause the outcome. And it is helpful to imagine that you're designing an RCT trial, and how would you describe the treatment to be given? So remember your PCOM. You have your population, intervention, comparison, and methodology. And that is your causal question as well. For example, does smoking cause lung cancer? What are the things that you want to know? So what type of smoking will be considered as exposed? Is it 1 pack of cigarettes per day? So what type of cigarette? Cigarette, cigar pipe, filter or unfiltered. Now there's vaping. Now there's nicotine patch, etc. Manner and frequency of inhalation. Age, initiation of smoking. How long have you been smoking? And what is a referent group? Smokers, non-smokers, or for example, smoking vape. Yet you have to define your causal question. And the smoking cause lung cancer. So among adults, the cigarette smoking at least 1 pack a day for 10 years cause lung cancer compared to never smoking at all. So again, you have your population, you have your intervention, you are specific, 1 pack a day for 10 years, causing lung cancer compared to never smoking. For example, insufficient physical activity. Can it cause death? So does having insufficient physical activity for 10 years cause death compared to having sufficient physical activity for 10 years? And this have immediate implications to public health policy. Okay. Does obesity cause death? Okay. Does having a BMI of 30 cause death within 10 years compared to having a BMI of 20? Okay. And what are the things that you have to know? So are there many possible ways of which an individual can have a BMI of 20? Could have diet, you could have liposuction, you could do smoking, tuberculosis, have cancer, and any other disease. And causal inference thinkers will debate on whether this is a truly answerable causal question. Okay. Exchangeability. So the treated and the untreated would have experienced the same risk of death if they had received the same treatment level. So the potential outcome and the actual treatment received are independent from each other. So this can be assumed in large randomized experiments due to randomization because only chance determines treatment category for each person. So the unrealistic expectation in observational studies would be that there may be variables that determine both the treatment and the outcome, but exchangeability can be achieved if all these variables are measured and controlled. So that is another assumption. And the last would be positivity. Okay, so positivity is the probability of receiving treatment is greater than 0 if all subjects receive the same treatment level. And to compute the average causal effect would be impossible. So the more precise the question, the higher the risk of non-passivity. So when conditioning occurs on other variables, there should be people at all levels of treatment in every level of L, wherein L or any subset of L cannot be strongly associated with the treatment. And the more variables to control, the more likely that you would violate positivity. That's why we ask you whenever you do your research, limit your variables. Only measure 1 or 2 so that your positivity will not be affected and the validity of the study would not be affected. Okay, then, and that's the last of my slides. Okay, any questions for this afternoon?